Assalamu alaikum, how are you all? This is the second part of ovarian mass related questions in short case. Previously, we have covered history, examination, and investigation related questions. So now comes the management. First of all, you have to make differentials. Examiner will ask what are your differentials depending upon your history, examination, and investigation. Always put your probable diagnosis first. Like if you are suspecting ovarian mass, then you will say my first differential is benign or malignant ovarian mass, then benign or malignant uterine masses, then you can say the non-gynecological masses. So these are the differentials I have taken from the guidelines of ovarian cyst in premenopausal women. And then questions from these flowcharts come, like in postmenopausal women, and if there is low likelihood of the malignancy, then who will operate, and if it is high likelihood of malignancy, then who will operate. So in this flowchart, referral and presentation of ovarian cyst has been given, and this flowchart targets specifically younger population, and here are different sizes and how to approach the cyst and how to follow up the cyst. Then next question being asked is the protocol of triaging women depending upon the RMI score. Low, intermediate and high risk. Low categorizes less than 25 RMI value and the risk is less than 3%. Then 25 to 250, the risk is 20%, and above 250 value risk is 75%. Then what are the steps of staging laparotomy? Starting from careful evaluation of all peritoneal surfaces, retrieval of any peritoneal fluid or ascites. If there is none, then washing should be taken, infracolic omentectomy, and selective lymphadenectomy of the pelvic and para-aortic lymph nodes, at least ipsilateral if the malignancy is unilateral. Biopsy or resection of any suspicious lesions, masses or adhesions. Random peritoneal biopsies of normal surfaces including from the undersurface of the right hemidiaphragm, bladder reflection, cul-de-sac, right and left paracolic races, and both pelvic side walls. Total abdominal hysterectomy and bilateral salpingophorectomy in most of the cases. Appendicectomy for mucinous tumors if the appendix appears abnormal. Then what are the types of surgeries we do perform in order to remove ovarian masses or treat ovarian malignancy? Then primary debulking surgery, cytoreductive surgery, second look surgery, interval debulking surgery, number 5 is palliative surgery, and number 6 is fertility sparing surgery. So what is the difference between debulking and cytoreductive surgery? Debulking typically refers to removing as much of the tumor as possible to reduce the burden, while cytoreductive surgery removes all the tumor, removal of all visible cancer cells. Interval debulking surgery refers to the surgery performed in the interval between the chemotherapy sessions. And second look surgery refers to the surgery to see the response of treatment. It is not usually practiced. Then fertility sparing surgery refers to the surgery in early stage disease and also in young patient who wishes to conceive. And palliative surgery is done in advanced stage. What are histopathological types of ovarian tumors? I have attached picture from the guidelines. And what are the stages of ovarian tumor? Both are taken from the guidelines. Regarding chemotherapy, they ask about the agents being used like platinum-based, taxanes, immune checkpoints inhibitors, and PARP inhibitors. Then taxanes include paclitaxel, docetaxel, cabazitaxels, and what is the mechanism of action? They inhibit the microtubules. Then side effects of the taxanes, I have mentioned all the side effects related to the taxanes. Then platinum based like cisplatin, carboplatin, oxaliplatin, and their possible side effects, and also what is platinum resistant, sensitive and refractory. They ask about the definition of the terms. And in case of granulosa cell tumor below 40, we can give bleomycin, etoposide and cisplatin, and above 40 we skip the bleomycin and give etoposide and cisplatin, and due to adverse effect of bleomycin we can skip the bleomycin, or we can reduce the dose from 30 to 20 units per meter square. In the cases in which patients are allergic to platinum based chemotherapy agents, we can give topotecan, pegylated liposomal doxorubicin hydrochloride, or paclitaxel as a single agent chemotherapy. This is how you follow up the patient 3 monthly after the treatment, and gradually you will increase the interval from 4 to 6 months, and then annual follow up after 5 years. On each visit you will ask about the history and emerging symptom and perform the physical examination, and ultrasonography can be done, and then CA 125 can be ordered, and CT scan will be planned accordingly. HRT can be given or not? Yes, HRT can be given, especially the patients who are having epithelial ovarian cancers. HRT can be given. However, the patient who are having serous ovarian tumors, it is a debate that either to give the HRT or not. But there is no set contraindication to the HRT in ovarian tumor patients. So stay tuned for my upcoming videos. Thank you everyone.